Assalamualaikum everyone. Today the topic of the presentation is the pathological and the molecular classification of the renal cell carcinoma. Starting with the introduction. Renal cell carcinoma, which originates within the renal cortex, are responsible for 80 to 85% of all primary renal tumors. Cloning of the susceptibility genes that are involved in the familial predisposition has offered entry points into the signaling pathways that are deregulated in the sporadic RCC. Sporadic RCC are extremely heterogeneous and are classified into many histological subtypes. By classification, there are two main types, that is the pathological subtype and the familial subtype. Distinct subtype of the RCC has been identified, including the following, that is clear cell carcinoma, papillary, chromophobe, oncocytic collecting duct, which is also called Bellini duct, happens very rare. Familial subtypes are the in which there is a Wien-Hippel-Lipton syndrome, Brit-Hop-Dew syndrome, succinate dehydrogenase, RCC, tuberous sclerosis, hereditary papillary RCC, and the familial leiomyomatosis. We will discuss them one by one. This is also the table which shows the familial RCC subtypes, in which the Wien-Hippel-Lindau disease associated with the gene mutation, that is the VHL gene, associated with the clear cell carcinoma. Similarly, the hereditary papillary RCC, the mutated gene is the c-Met proto-oncogene, is associated with the multiple and bilateral type 1 papillary RCC. Similarly, the familial type also shows the subtypes of the RCC with the gene mutation. This is the pathological subtype of the histological subtype of the RCC, in which the very much occurring is the clear cell RCC, that is 70 to 80%, then papillary RCC, which occurs 10 to 15%, chromophobe RCC, which occurs 3 to 5%, and then collecting the renal medullary and the translocation RCC, that is what initially there is the classification of the by the histological RCC are only the four types, that is the glandular and sarcomatoid RCC, clear cell RCC, and the granular RCC. But by the recent advancement and the histological pathology identification, it is easy for us to subdivide and subtype the RCC into these subtype, pathological or histological subtypes. Starting from the clear cell RCC, that is clear cell RCC, which typically have a deletion of a chromosome 3p and arise from the proximal convoluted tubules. On the gross examination, it is yellow when bivalve and highly vascularized. Microscopically, it consists of sheets or nets of the clear cell with round and polygonal cytoplasm with delicate vascular network, having a worse prognosis as compared to the papillary and the chromophobe RCC. Having a gene mutation with the loss of the chromosome 3p at the 3p 25 to 26, which occurs 94%, there is a gene which is a VHL gene involved. There's lots of work has been done on the clear cell carcinoma, so it is easy for us to or allow us to identify other than that mutations to identify. That is the BRCA1 associated with the BAP1 3p having a pathway UMP. Protein polybromo 1, which also got the PRIM1, having a truncated mutation at the 3p21. Inactivation of the histone modifying gene, having a gene mutation at the SET2 and JARID1C. The common pathway, which is having the common pathway that is belong with the tumorigenesis in the clear cell RCC is the VHL-IHF pathway. Other than that, there is a Pi3K AKT pathway and SWI/SNF chromatin remodeling. It's a chromatin modeling complex through which this pathway, the tumorigenesis, also occurs. Other mutation which is found, this is the mentioned here in the following. So this is the VHF pathway. This is the oxygen sensing pathway. So what happens when there is a functional VHL gene? There is the complex of the protein VHL and the ubiquitinase E3. These two complexes work together through proteasome in the normoxia position or the condition. There is a degradation of the hypoxia-induced factors, which doesn't lead to the formation of the various factors. But when happens when there is a VHL gene mutation occurs, there is the inhibition of this VHL protein and the ubiquitinase, leading the cell in the hypoxic state, and hence the accumulation of the hypoxia-induced factors lead to the formation of the or the increased expression of the vascular endothelial growth factors, platelet derived growth factors, GLUT factors, and erythropoietin, which all leads to the angiogenesis and the inflammation, which leads to the tumorigenesis, and the programmed cell death, that is the apoptosis, also inhibited through this all mechanism. Coming towards the Whipple-Lindau disease, that is autosomal dominant disorder, having a major manifestation with the RCC. Other than that, with having pheochromocytoma, retinal angiomas, and hemangioblastomas of the brainstem or the spinal cord. Other than that, is also associated with the pancreatic cyst, inner ear tumors, papillary cyst, adenomas, and epididymis of the epididymis. VHL genes, the variation of these all papillomas and the hemangioblastomas occurs because this is the VHL gene, which consists of the 3 exons that encodes 213 proteins. Whenever the mutation occurs, these all proteins lost their function, and hence this all manifestations of the disease occurs. Having two types, that is type 1 and type 2. Type 2 is also subdivided or subtype, having type 2 A, B, C, while type 2 is associated with the pheochromocytoma. Then there is the papillary RCC, which happens second most common histopathological subtype. Having a 2 subtype, that is corresponds with the 2 familial syndromes, that is hereditary papillary renal cell carcinoma, having a median age of 45 years, multifocal and bilateral, and hypovascular. Hereditary leiomyomatosis RCC, having a median age 35 years, solitary developed cutaneous and uterine leiomyomas. On gross examination, it has a beige to white in color, frequent hemorrhages that may mimic as a cyst. Microscopically, it has 2 variants. Type 1 consists of a basophilic cells with scant cytoplasm, this is type 1. And the type 2 having a pseudo-stratified nuclei of the high nuclear grade with eosinophilic cell and the abundant granular cytoplasm. Type 1 HPRCC associated with the C proto-oncogene, which is located on the chromosome 7q31, showing the type of the mutation can be activating mutation, splice variant, or the gene fusion. The hereditary leiomyomatosis associated with the fumarate hydratase gene mutation, which is a tumor suppressor gene, on located chromosome 1q42 to 44. So this is a pathway through which the papillary RCC type 1 occurs, that is the hepatocyte growth factor. As I told you that the CMAT is a proto-oncogene. When the mutation occurs, this proto-oncogene turns into the oncogene. So when there is the hepatocyte growth factor and the MAT binds with the extracellular portion, leads to the cascade of the pathways, that is the PI3K AKT pathway, MAPK pathway, and the transcription pathway. These all are negatively regulated pathways, but in the mutation of this MAT gene, these are regulated positively, and hence do the cell survival, mortality, and the proliferation leads to the tumorigenesis of the RCC. Second pathway, that is the hereditary leiomyomatosis pathway, that is the mitochondrial metabolic pathway type 2. in which what occurs that there is a impaired oxidative phosphorylation. Why happened? Because there is a fume rate which doesn't turn because into the malate, and hence there is a lack of the TCA cycle, leading to the cell into the hypoxic state, which we said as a Warburg effect. What is Warburg effect? Is that in the metabolism of a normal cell, the glucose through the glucose, that is the oxidative phosphorylation, the end product lactate is low, and the TCA cycle through which the ATP generated is high. But in this tumor cells, they appoint themselves, or they adopt themselves as a hypoxic state and lead to the through the glucose oxidative phosphorylation is impaired. There's only 12 ATP generated through this pathway, and the aerobic glycolysis, the energy formation has taken place. This is called the Warburg effect. Second, what happened here is that there is a decreased AMPK levels. What is this? This is a factor which is an energy sensor factor in the cell. With this hypoxic state, there is a low level of the AMPK, low level of the P53, and hence the cytosolic iron is also decreased. Third, what happened that with this impaired cycle, there also the decreased AMPK level associated with the decreased acetyl CoA formation, which is a rate limiting step for the fatty acid synthesis. When this impaired, there is an increased fatty acid synthesis and the phospholipid occurs. All these things lead to the accumulation of the hypoxia-induced factor 1 alpha, which leads to the increased production of the VEGF GLUT1, and hence the tumorigenesis is started in this RCC, or the type 2 papillary RCC. Now coming towards the chromophobe RCC, which is histologically are composed of sheets of the polygonal cells that are darker than the clear cell carcinoma, characterized by the atypical nuclei, lack of abundant lipid and glycogen, thick-walled vessels, focal classification in the broad fibrotic septa, associated with the big tube Hawk syndrome, in which the BHD gene located on the 17p12q11.2 and is characterized by the cutaneous fibrofollicular mass, lung cyst, and the spontaneous pneumothorax due to the lung cyst. In this, there is a gene mutation. This is the FLCN gene that encodes for the folliculin protein located on the chromosome 17 and 19 along with other chromosome sites. Type of the mutation occurs insertion, either deletion, nonsense, or the loss of the second copy or loss of the heterozygosity at the FLCN locus. So this is the pathway. This is the AMPK mTOR pathway. So what happens here that with this FLCN gene that is regulated with the FNP1 and the FNP2, there's a kinase which regulate the energy sensing levels of the AMPK, which in turn inhibit the mTOR pathway. When this mutation occurs, this all pathway inhibited, and hence the mTOR pathway through there is the PIKT pathway, there is a tumorigenesis occurs. So with all these molecular classifications and coming to know that what are the factors which are induce this pathogenesis in the renal cell carcinoma, we came to conclude the targeted therapy. So we all know that all type of the pathway leads to the accumulation of the HIF, that is a hypoxia-induced factor, and which in turn leads to these factors which form the growth, cell growth, proliferation, angiogenesis, and the of the cell. So by the mTOR pathway, that is everolimus and the temsirolimus, which has a good response in the chromophobe RCC, it can be showing the promising results and the prognosis in the chromophobe RCC. By TKIs, the major factors, that is the VEGF and the PDGF receptors, by the sunitinib and the pazopanib, showing the promising result, but the further evaluation is also in order. There is a monoclonal antibody, that is the bevacizumab, shows the interaction binds with the VGF factor. VGF, what it does by binding it, it sequesters this ligand, so it does not interact with the receptor, and hence angiogenesis can be halted. So with all these developments, we came to know that these are the factors through which we can have or treat the metastatic RCC in a possible way. Other molecular markers are the cadherin-9 molecular marker, which is regulated by the VHL gene and hence having a prognostic factor for the clear cell carcinoma. Having this increased level of the molecular marker, having a bad prognosis or a poor prognosis with the clear cell carcinoma. Another is the Chi-67, which is a proliferative index, which is a surrogate for the histologic necrosis. Here is the mention the program that L1, that is a PD-L1 ligand, also called as the B7H1. It is the T cell co-regulatory molecule and expressed by the macrophage lineage. So what it does, that tumor associated with the PD-L1 show how it improves the antigen-specific T cell function, and by blocking this with the atezolizumab, showing the promising results in the metastatic RCC. Similarly, there is a cytotoxic T lymphocyte antigen 4 expressed on the T cell, and it helps with the immune response to the T cell immune response to the tumor cells. So by targeting it with the ipilimumab, showing the potentiate effects on the metastatic RCC, but still work is in process. Coming to the rare form of the RCC, that is the collecting duct RCC, also called as balloon duct RCC, occurs very rare, tends to occur in the younger age, more commonly presented in the metastatic stage. Microscopically, it is characterized by the admixture of the dilated tubules and the papillary structures, typically lined by cuboidal cells, giving the cobblestone appearance. Deletion on chromosome 1q is the most commonly found. Monosomy of the chromosome 8, more aggressive and has poor prognosis. The gene involved in this is that NF2 and CDK and 2A. Renal medullary carcinoma, that is originates from the renal papilla. It is a subtype of the RCC which exclusively associated with the sickle cell disease, occurs in the third decade of life. Presented locally advanced and metastatic stage with a mean survival of 5 months. The gene involved in this is the SMARCB1, is a component of the chromatin complex, which I've already told that this complex is a chromatin complex, and it acts as a tumor suppressor gene. According to the RECIST criteria, platinum-based regime trial given response, showing the response of short-lived and median survival of 2.5 months only. Another variant is the RCC with the sarcomatoid. Differentiation occurs found in the 1 to 5% of the RCC with clear cell or the chromophobe, characterized by the spindle cells, stain positive for the vimentin, infiltrative and a metastatic behavior, having a poor prognosis. IL-2 based immunotherapy, chemotherapy or targeted molecular therapy is required after the surgery. Another type is the translocation RCC. This is defined as chromosomal translocation at XB11.2 associated with the fusion of TF3 genes, including PRCC and ASPL. Having a mean age of 24 years, woman incidence is more than the man, shows more sensitive to the chemotherapeutic agents such as vincristine and paclitaxel. Another familial disease is the tuberous sclerosis, is an autosomal dominant associated with the AML. 20 to 30% AML occurs in the patient with TCS, and while 50% of the tuberous sclerosis develop AML, having a 2 gene, that is a TCS1 chromosome located on the 9q encoding Hummerton, and TCS2 chromosome that is located on 16p that is encoding for the tuberin. Loss of the TCS2 protein as a result of a TCS2 mutation and activation of leads to the activation of the mTOR pathway. Ablation therapies may have their best role with the multicentric AML, mTOR imitators has good response, that is sirolimus and the everolimus. Coming to the take-home message is for the development of the novel approaches, it is important to understand the molecular pathogenesis and its pathway, not only to increase the survival of the patient, but to help in overcoming the tumor heterogeneity and avoid treatment resistance. Thank you, and these are the references taken for the presentation.
Go back to the class slide. Right. So this is a very interesting and important. Again, all the topics are important topics. But to understand renal cell carcinoma or renal tumors, we have to add another chapter to our understanding of the whole science of urology. You see, what we lack in our training and understanding is something called genetics and molecular biology. Now, this has got an implication. This has got an implication in terms of treatment, as it was explained here in the take-home message, and again in one of the slides where you have pointed out certain treatment strategies which are linked with this concept of molecular biology. You go back to that slide. This one, yes. Now, for any person, any one of us who is in the process of dealing with a patient with renal tumor, sometimes it is kind of discouraging whenever we have only one option. Sometimes it is kind of encouraging if we have got only one option. For instance, if you have got only one option and that is surgery, which was the case earlier for renal tumor, maybe 10 years back or 20 years back, you don't have to think anything beyond surgery. Now, it's only the surgeon and his or her skill, the use of knife, because that was the only thing available, and the exploitation of anatomy and anatomical planes, that's all. That can give you an edge over something which is actually multiplying in many directions, and that is tumor. So for any tumor, if you think that it is something with an unknown etiology, now the whole picture is very simple. You don't have to put yourself in a lot. You just have to train your fingers, and if you are not born with green fingers, you can make your fingers green. By meaning green, I mean to say you just practice them and they become nimble. They can just dissect anything in front of you. It only needs a little bit of time for any person who is not gifted. If that person puts in a lot of time in practice, that person becomes an expert again. So the pathway to become an expert or to become someone who can deal with a renal tumor, for instance, it was not that complex. It was rather very easy. Maybe it is slightly uphill for someone and maybe not so tedious for another person. Now, coming back to this slide, if you are in the process, and the scientists and all the researchers around the world are always in the process of thinking something that there must be a cause and effect relationship. There is nothing called unknown etiology. It is something which is actually, you have got a snapshot in a time when you say that my knowledge is not up to the point where I can tell you how it has been produced or it has been developed in that form, for instance, tumor. But you can't say that it will remain as such for the next many, many years to come. So the quest should always be there, and that was there. Now it has given you some the fruits of those endeavors. Now there are certain pathways which are actually here. Now there are other certain pathways which we can understand if we go back to the basic books of molecular biology. And that was something which was actually started in the late 90s in the field of urology. Now everything is coming up to three steps. Now one is the hypoxia-induced factor. the angiogenesis. And that is very basic, because if you produce something called hypoxia in an environment around a cell, if that cell is actually in the process of having to live longer, now this factor will always produce something called angiogenesis. So it's a kind of a rule that is there for many other say tumors and cell cultures. If that point is understood by us, then we can exploit this point to have something called mTOR inhibitor, so that can do away with the tumor in its budding stage. The second point is this one, the lower, the sunitinib and sorafenib. Now again, there are certain factors which are growth factors. So if you understand this process, then you can exploit this process by having these drugs, and these are being used for metastatic renal tumors, and they are now part of our strategy of dealing with tumors, even here in our unit in SIUT. The third one is this Zumab. Now Zumab is something which is actually monoclonal antibody, and we are now surprisingly, we are at a stage where we can understand, because all of us are in the process of going through a COVID-19 crisis. So we all know what this monoclonal antibody is, because we are using something called tocilizumab. Now, all these Zumabs, they are monoclonal antibodies, and we have got an advantage of understanding it. For the past many years, probably 30 years, 25 years, we know that there is something called monoclonal antibody, because we are dealing with patients of transplant. Now, when the rejection process has gone on to a stage where it cannot be tackled by, for instance, steroid, then we go towards ATG, which is polyclonal, and then we go towards something called OKT3, the historical one, and that was monoclonal. So now, if we have got that kind of a understanding at the back of our mind, we can understand that we can exploit again that pathway, which is actually something to go hand in hand with tumorigenesis. So you see, now the picture for us is becoming complicated, but now is the point to understand and to pick the treatment which is actually suited to our particular patient. So it is now rather custom made, it has become tailor made. You have to take every patient separately, classify that patient with that patient's tumor separately, devise a strategy which is not a kind of a carpet strategy. It is something which is an individualized strategy. And since you have got many options, now you can have many different strategies for a single tumor. So now the picture is, for many of us, is not that complicated, but it is advantageous. When you have got a lot of weapons in your hand, then you can always have, say, a positive sense in having some success. So now the light is more as compared to earlier, 20 years back. So we can, at that time, maybe we can see a little bit of flicker at the end of the tunnel. Now we can see a beacon of light at the end of the tunnel. That's what my reaction to the whole subject of renal tumor is. So now there is nothing called negative depression sort of a thing for tumor therapy. There are positive, say, vibes coming out of it. When I was starting my residency many years back, we had one professor, a professor of medicine, and he was a very gifted professor of medicine in civil hospital. He came to us with one of his patients for lithotripsy, and I was just talking to him, chit chat. He was saying that many things in medicine have been explained quite elaborately, but there is one thing left, and that discussion was actually in 1994, I think, or 1993. So he says that there is only one thing left in medicine, and that is tumor and oncology. So that's the only riddle that needs to be broken down, and we have to have something And he was so depressed and sort of I can see something on his face. That he says that I can treat any patient with any kind of a disease through medicine, but whenever somebody comes to me with a tumor, I say no, I can't do anything. So that was a statement from somebody who was at that time. I'm not telling you the name of that person, but he was a person who was somebody who was gifted, somebody who always gives you the answer from the aspect of medicine. He was the professor of medicine and the head of the Department of Medicine, Pathological College Civil Hospital. But that's the kind of environment that was there 25 years, 30 years back. But now we have got these things. Now, if that professor would have been in this world now, he will be very happy. He will be happy in a way because now he can understand. And nobody can be more happier who can understand what's happening around him. So that's it. Thank you very much.